So when I published a piece in the Times called The Obscene Profits of Nonprofit Hospitals, you can imagine that some parts of my employers were less than pleased, but I didn't point fingers. I pointed out, I wrote about what was obvious and why that's not good for patient care. And so I try to really ground it in doing our job for our patients, because it is important that people hear this and that they don't, know what's going on. I mean, right now with all the chaos happening in our public health system, I think we do have to stand up very loudly. And I've been impressed that many people have. And it may not always be effective in the short run, but in the long run, it is showing a spine of the medical profession. I think that, there's the line that we can't cross is when this is going to be harming our patients. And if patients are going to start dying of diseases that we've already know how to treat and prevent, we cannot just let this go.
Welcome to How I Doctor, where we're bringing joy back to medicine. Today, I'm joined by Dr. Danielle Ofri, physician, writer, fellow cellist, and one of the clearest voices we have about what it feels like to practice medicine in America. She spent her career as an internist at Bellevue Hospital and clinical professor at NYU in New York, caring for some of the most vulnerable patients in one of the most storied hospitals in the country. She's also editor-in-chief of the Bellevue Literary Review, the first literary journal to emerge from a medical center, and the author of multiple books and essays that really cut to the heart of medicine. Her 2019 New York Times op-ed on the emotional toll of medical work struck a nerve with me. I think about it weekly because I think it so perfectly summarizes the state of medicine today. Dr. Ofri doesn't just write about burnout or moral injury as abstract concepts, but she really names what so many of us feel but rarely say out loud. I'm excited to talk with her today about the system we're all working in, the stories that we tell as doctors, and how we can still find meaning and humanity in the work that gets harder and harder every year. Welcome to How I Doctor, Danielle Ofri. Thank you so much for being here.
Thank you, Graham. It's great to be here.
Danielle, I literally have your New York Times op-ed on speed dial. I have it like as a link in my bookmarks that makes it really easy for me to pull up and send to other people. If you haven't read it, it's called The Business of Healthcare Depends on Exploiting Doctors and Nurses. I love the title, but I love the text even more. Danielle, you wrote that before COVID, which I think is also really telling. I think so much of medicine today, we maybe want to blame on COVID, but I think many of these challenges started, at least a decade ago, if not longer.
You write lots of stuff and put stuff out there, but that's the one article that people keep coming back to. And I think because, and inadvertently, I would say, I ended up tapping into what I think is an essential issue of what's wrong and maybe also what's right with medicine today. We all love what we do and we love who we work with. And one of the reasons we love who we work with is that we share this ethic. Every time I pass by my hospital, I actually live nearby, so I sometimes pass it at night, and I realize that the chain has never been broken. When I signed out my last day of residency in the MICU, I signed out to someone else who signed to someone else, and that chain has never been broken.
I love that.
And I know that all the time because we never let that ball drop. Every nurse shift that ends is signed out to the next nurse, and that has not stopped in all my years and decades of medicine, and all the years we've all been practicing. That's just an amazing miracle of what we do, which is why I feel like medicine and nursing is less of a job than an identity of who we are. But then I look at how the institution of healthcare as an industry is working, and it relies on that. And I initially didn't want to say exploits.
Yeah, did you get to pick that headline? I know often the editors choose for you.
The editors, the headlines are all the business of the newspaper or the journal. But I think that it became apparent that is the mortar that holds up the house that is healthcare. And if we all clocked out at the end of our hours, the end of our shift, the end of whatever our to-do list is, it would crumble in a second. It wouldn't last more than a minute because, today's Friday, I don't see patients today. But of course, I'm logged into Epic and I missed a patient yesterday who has dementia, so we called and did a televisit today. I have a patient who's seeing a PA. I know that the potassium is low and they need to change their blood pressure medications, and I made sure that got through because I can't go off to my weekend until that's done. Just it doesn't work that way. And so as the business of healthcare expands, and basically this is looking to make money, at least in this country, you can keep expanding. And one of the things that turns out to be absolutely elastic is the professionalism of doctors and nurses. And if they didn't have that, none of this could happen.
It does feel like that oath that I took. It wasn't technically the Hippocratic Oath. It was a modified one we took at Stanford. But that oath certainly feels like it is abused and relied upon. And in fact, I've had doctors on this podcast tell me they know administrators who've said, well, you know what, the doctors will do it because it's in the name of patient care. So we'll just use that. The administrator is getting a business outcome that they want, essentially free labor or cheaper labor. And but the doctor is going to do it because it's the right thing to do.
We have 20-minute patient visits because our patients are very complex. Most don't speak English, a lot of psychosocial issues. Even then, most visits take well longer than that. But for new patients, we were given 40 minutes. But the backlog of new patients who were waiting for medical care was so enormous. And the solution became to cut those new patient sessions into 20 minutes so you could see double the number. Now, of course, there isn't any extra time given or extras. It's just twice as much work. And of course, every one of those patients generates a ton of work, labs, new diagnoses. Some of these patients, I had a new patient who was 2 weeks post-discharge after a month intubated in the CCU with
gosh.
new onset heart failure, who spoke only Haitian Creole. And I thought, okay, 20 minutes? I can't even read the consults, read the discharge summary in 20 minutes. And so the only way that works is because we will not leave without reviewing the labs or finishing the time. I had another new patient who spoke only Venezuelan ASL, sign language. I had to have a Venezuelan and an American sign interpreter plus me. So a 3-way chain. And of course, it took an hour. And you just can't, and of course, I can't stop. I can't skip the allergies or the past surgical history. You can't just, not do those things. So yes, and where does the time come from? It's our free time, which of course we understand and accept. We're not shift workers in that sense. Nevertheless, there's a point where it becomes exploitation. We realize, well, we can just add more work and that'll get more efficiency or more profit because we know the nurses and doctors won't leave until their work is done.
I struggle with this a lot. Is there a line? Is that line dynamic? I do truly feel that this is a profession. This is a calling. I think people younger than me are maybe more likely to think of it as a job. But where is that line where it becomes maybe exploitative versus just part of being a calling?
It's very hard to draw an absolute line, but I think when we distinguish between the emergencies and the routine, when we do this routinely, if it's all a state of emergency is a routine thing, then we've become exploitative. But also, when I think in terms of when is it beginning to harm patients? Now, of course, we'd love to say when it harms clinicians, but I don't think that the higher-ups really care, honestly, other than lip service. But harm to patients, medical errors, lawsuits, those do actually count, thank goodness. But we can point out when we feel that, for example, when I've cut corners with a new patient, I have one of my new patients, I realized that I didn't confirm which diuretic he was on and which dose. And, it tormented me. I kind of had to keep calling and tracking down for days till I got him and pinned him down. Is it LASIK or Bumix? And how much? Or none at all. Right. Because I can't leave that stone unturned, that it feels wrong. And that happens not infrequently. I also had a time when I had 2 new patients, Spanish-speaking middle-aged women, who both walked in with A1Cs over 9, that is, newly diagnosed diabetes, and one had a TSH of 300 of hypothyroidism. And these just sort of floated in, and I mixed them up. I called one back twice because I got just confused and thought that this is dangerous. And so when we start having patient harm, I think we're, of course, ethically obliged to speak up. This is harming our patients because that goes right against our oath. I wish the idea of our own well-being mattered, but I know that it doesn't really.
I think many people view healthcare as like inefficient or slow, or doctors aren't trying to be innovative enough. But the challenges you described of like trying to help care for another human being who speaks Venezuelan sign language, that is a real human being, and you we as physicians, we have the same oath to that person that where it takes more time as we do to the person that speaks English.
We kind of treat doctors, nurses, as well as patients as these interchangeable widgets. Well, we'll just sub out this patient for that or this doctor for that. And it's really not the case at all. As anyone in healthcare knows, that patients come in all sizes and shapes and different levels of medical complexity and different levels of social needs. I mean, I think that people have a lot of psychosocial needs that we can't just blow off as the touchy-feely stuff. That is, I mean, anyone who's been around in medicine long enough knows those are essential. If you don't address what's happening in the real life of the patient, you will never get to the diabetes or the blood pressure because that's so low on their list, and we have to address that. And then we also know that different clinicians have different strengths and weaknesses. And we sometimes, let's just throw a PA in here for an MD, which in some cases is fine, but in some cases is not. And they're not just interchangeable widgets.
Dr. Ofri, I wonder what you say to maybe medical students or residents that do feel like this is a job. Many of them want more shift work. They maybe think it is not their responsibility to track down the patient and figure if they're on Lasix or torsemide or Bumex, and it's the health system's responsibility, or it's the insurer's responsibility. Like, how do you have that conversation?
So there's two parts to that question. There's nothing wrong with shift work. I mean,
Yeah.
ER docs work shifts, clinic doctors work shifts. Now, of course, those shifts sometimes are a bit elastic. But I think it's not a sin to want a life that, begins at 5 p.m. You don't have to work till midnight every night. And I think we shouldn't be disparaging doctors for wanting a life outside of medicine. That is fine. I think we do have to make clear that this is a profession and not just a job. And so if you are not able to stay to track down the potassium, you do have to make sure that will be checked by someone, that there should be coverage to sign it out to,
Yeah,
but you
sure.
can't go until the chain is completed. And that part is your responsibility. And then I asked them, what if this were you or your parent or your child? You want that nurse to take the extra 5 minutes to make sure the sign out is there. So making that connection. On the other hand, I think it is right to demand that the system step up because it is leaning on this professionalism and then to some degree exploiting it, that many of these things can be solved by systems. Like, for example, is there coverage? I mean, some places don't have coverage and it's just you and you alone. So insisting on that is very important. Again, the patient safety issue is, I think, the way to make the case, because that's where things matter higher up.
I really like that visual and that symbol of like not letting the chain break. That the chain has, the chain has fundamentally never been broken. And yeah, the system should, if you're getting the potassium at 6 p.m. and you are about to walk out the door, the system should have a way to make it easy to keep that chain from being broken. Maybe it doesn't have to be you every time, but the system should be supporting that so the chain stays
Absolutely.
supported.
Absolutely.
Yeah. If you could snap your fingers and fix one piece of the healthcare system, is there one that comes to mind that you would instantly jump to fixing?
Yes, fully staff the nursing corps. That if we had enough nurses on the floors, in the clinics and practices, medicine would be revolutionized. I once I did some temp work after residency, and I worked in a practice where I had a one-on-one RN. I've never been such a good doctor when I had a brilliant partner.
Yes.
And I realized, wow, when you have a team that's, excellent and has good standards and enough of them, you can really do a lot of these things. And I think the nursing shortage is so critical. And there's study after study that correlates nursing shortage and mortality. You can even track it to, one nurse less on the ward per shift, and you can see the mortality go up by a fixed percentage. Every time there's a call out, it matters greatly. Secondarily, I think we need more doctors, but I think if we could magically double the nurse pool, with appropriate pay, commensurate with experience, and fully staff every ward in the way they should be staffed, I think a lot of this could be eased.
I love that. I'm an ER doctor. When I am on with I mean, I love all my nurses.
Right.
When I'm on with my favorite nurses, that we just kind of vibe, and they've been around me long enough, and I've been around them long enough that we are just kind of in the zone together. And they, I forgot to order the type in screen, and then I say, "Oh, I'm so sorry. Oh, I already ordered it. I already sent it." I mean, just the ability to be in lockstep with the nurse and get the care and help the patient. I mean, it is certainly like in the zone feeling, and it feels so wonderful as well to have that partner in that relationship.
Right. And for the patient, I mean, if you ask a patient on the ward the name of their doctor, they'll probably draw a blank, but ask them the name of their nurse and they will know because the nurse
Absolutely.
is really doing the medical care and having enough nurse time. They often talk about patient satisfaction. Oh, we'll have valet parking and coffee machines and graham crackers. No, just give them more, like, tell the patient when they press the nursing button, someone will come right away. That's what most patients want. They don't care about the coffee machine if they have enough nurses on the floor. Triage and the urgent care, that really matters to have enough nurses and really good nurses to be able to do this, and the patients benefit immensely. One thing during the COVID pandemic that was really interesting to me, it's like the vasculature of the hospital became apparent that you saw what it took. Like the role of housekeeping during the early days of the pandemic in the ED, it was incredible. We could not have functioned without, if all the housekeeping staff had left or was afraid and all walked out, we couldn't have taken care of the patients. But really watching how things work, because it's often invisible to us. But suddenly seeing, for example, when we had to convert 54 ICU rooms into negative pressure rooms, to watch the teams go around and do that, the maintenance teams, was brilliant. And it really gave us, I think, quite a view out of our silos to see what it takes to make a hospital run.
Just now you seeing the vasculature of the hospital, like, God, I just love the way your brain is able to take medical things and then kind of anthropomorphize them, because that God, the way you described that was just so brilliant.
Well, I'll tell you, I sweated over that because this is from, I wrote a New Yorker piece about our experience in the COVID pandemic. And that's where I sweated on that one. It didn't just come out of the air.
You've written for the New York Times, the New Yorker, you've published books, essays. Like, what was the motivation that made you say, I want to start sharing my perspective beyond just talking to my coworkers?
Well, there actually was not the motivation at all. When I finished residency, I ended up taking off a year and a half to travel. So I did locum tenens, which I knew nothing about, but a resident said, "Oh, there's this, you can travel around." I'm like, "Oh, that sounds good." I did an MD PhD, so I had been in training for just many, many years. And I never taken a break ever, but I went and I worked in these small towns, mostly rural New Mexico, rural Florida, New Hampshire, where there's basically doctor shortages that you're not aware of when you work in the big city. And so it was fascinating to see medicine practiced in other ways, which I had not been aware of. But also, there was nothing to do. I live in Manhattan, so living in these small towns, there's truly nothing to do. But I had just left 10 years of medical training and really filled to the bursting with all these intense stories with no place to put them. And so what I finally started writing was just a place to put these stories down. And I really shy away from the word, closure. There's no such thing as closure, but you can't leave an open wound all the time. The edges are too ragged and it's very hard to function. You don't want to bury it completely either. So so writing was a way to put them somewhere, to wrestle with them, to grapple with them, to spend time with them, and then let them settle somewhere. And that's really how I started.
I'll have ideas that get in my head, and I don't have a way to get them out except with writing them down. And sometimes they flow, and they're very easy to get out on the page or on the screen, and other times it takes a few sessions because it still feels unsettled in my head.
I just spent the last 2 or 3 years really thinking hard about this. I just over the summer published a piece in the New Yorker called "Why Do Doctors Write?" When I've
Yeah.
been wrestling with that and thinking about the books that influenced me and how it helped me through my training to understand the things that were not in the syllabus, the really interstitial parts of medicine really came through when I read Abraham Verghese and Oliver Sacks and Perry Klass and Sherwin Nuland, all these great writers, Anton Chekhov. that brought things out that, oh, that's what that is. Now I've got a name for it. I've got someone's identified that. It made me feel less alone. Because all these things, and you come in as a newbie into this world, you're being dropped into the planet Mars. You can't even speak the language or wear the right clothes or say the right things. You're just a sore thumb. And these books were my guides.
I talk to a lot of physicians who want to write or want to just speak out more publicly about their challenges, their frustrations with the health system. What do you tell people? I think a lot of physicians feel some risk there, that they're going to get in trouble, they're going to get fired, they're going to get penalized in some way. But there is an urge to tell these stories and tell them honestly and truthfully about what's really happening with their patients and the way they're practicing medicine.
There's two parts to that question. So one is about patient privacy, and that's
Of course.
different. So certainly what we choose to write about patients, you do need to get permission when you can, or just use broad outlines, unidentifiable patients. That's one thing. But separately, the idea of writing and speaking your mind, I think it's our duty to do so, to be honest. I mean, I don't air dirty laundry. I don't disparage my institutions. I don't hit under the belt. I really don't. Now, that doesn't mean I don't aggravate some of the higher ups. That is true. But I try to not be hyperbolic and to be as intellectually honest as possible. So you're right. They may not like it. So when I published a piece in the Times called The Obscene Profits of Nonprofit Hospitals, you can imagine that some parts of my employers were less than pleased, but I didn't point fingers. I pointed out, I wrote about what was obvious and why that's not good for patient care. And so I try to really ground it in doing our job for our patients, because it is important that people hear this, and that they don't, know what's going on. I mean, right now with all the chaos happening in our public health system, I think we do have to stand up very loudly. And I've been impressed that many people have. And it may not always be effective in the short run, but in the long run, it is showing a spine of the medical profession. I think that, there's the line that we can't cross is when this is going to be harming our patients. And if patients are going to start dying of diseases that we've already know how to treat and prevent, we cannot just let this go.
Yeah, I am feeling like medicine is starting to use that spine that we haven't maybe needed to use in a long time.
I think that the public may not recognize. I was trying to describe in an article about how when you as a patient see your doctor, you're a nurse, it's not just you there. There's a whole kind of choir of people in the background there. Public health researchers, policymakers, analysts, population health people, all these people, regulators who are making this happen, that you as a patient you just see your doctor write a prescription, but it takes a lot to do that. I mean, we're in some ways exposing the vasculature of our public health system when we see it being, degraded, and we see what happens when you take away people with vaccine expertise, you kick them off the panel and put on people without expertise who have a political axe to grind. You can see what happens, and that what we've taken for granted is that, people in the CDC and the FDA, they're experienced, they're trying to do the right thing. They make mistakes, but basically that's their North Star. But we see now in stark relief what happens when that's not the case. I mean, can we recover? I hope so. And I try to remain optimistic that we can. I look back historically of things we have recovered from. You can go back as far as even the Civil War, which you could say to some degree we have not fully recovered from, and that is true. But given where things were at the moment, and where it would be hard to imagine if you were in that moment to see that would the killing stop? Would people start going back to their jobs? All these things would not have seemed possible post-World War I, post-World War II. So there's a resilience that I'm counting on.
Do you think that physician, complacency or just not being as vocal has allowed others, health system executives, politicians, influencers to kind of shape public perception of our profession and what we do? Like, is this a little bit on us that we?
Yeah, I think so. I mean, partly is we have I think a tradition of reticence that, we as a profession try not to be brash. We do our job, you do it right. It's in the quiet of an exam room. It's not out in public on a TikTok video. We just do our thing, and the only person who knows is the patient. And that's really been our MO. But I think also we certainly made many mistakes during the pandemic. And I think, and many of them were done with good intentions, that we can look back and be open about maybe we kept schools closed too long. Maybe our discussions weren't transparent enough. We certainly could have communicated better. But I think, making clear to the world how we do things. How does the CDC work? How does the ACIP, the Vaccine Council work? All these things I think people don't know about, how the FDA works. And listen, it's hard to communicate. But yeah, as a profession, I think that we didn't make ourselves our thought process as well known as we could have. Also, I think there's been quite a bit of greed in healthcare, and physicians and healthcare companies have been part of that. I mean, there are many very wealthy physicians in certain surgical subspecialties that, are quite ostentatious. There are health centers that look like luxury hotels. And it's understandable for patients saying, hey, wait a second, I'm paying this huge copay and I walk into this place and it's got fountains and, so there's a big disconnect. I think healthcare has abused the nonprofit status. And I think, the at last count, 7 of the top 10 most profitable hospitals were nonprofit. Well, there's something profoundly wrong there. And nonprofit status, of course, is a gift to the taxpayer. We own that. That's money that you're taking away from our, police forces, education, road repair. And so there's been abuse of that, the CEO salaries of healthcare centers. The arms race of gobbling up places in the monopolies, and the things like hospital outpatient departments, where
all the billing tricks,
the billing tricks, all of that. Now, part of that is because we have a capitalist system for healthcare. We've treated healthcare like microwaves, and you can just, make more, charge more, and we haven't accepted that it's going to be a way that we have to rethink that. So that's a whole societal thing that we need to do.
Yeah.
Anyway, so we definitely have a part of it. It's not all on the clinicians. I think health insurance, pharma, these monster healthcare conglomerates have a big role in that. And I think, and it may be that physicians and nurses need to have been speaking up a little bit about what's wrong with that. How does that work against patient care?
I completely agree. Physicians have a role in this as well. It's our CPT codes and it's our RVU committees that decide reimbursement for procedures over primary care. I think the thing that is the challenge that I feel a lot is we are viewed as the boss and that we're in charge and that we run the show. And so patients then get upset with us when their insurer requires prior auth and we didn't get the approval, or their PBM switched their asthma medicine or something. And because those are nameless, faceless corporations making these policy decisions, but we are the human in the room, to me, it feels like some of the trust erosion is should not be directed toward us, but it is.
Agreed. And it's very hard for patients. And I get phone calls from the pharmacy. I'm standing here and my insulin costs $400 now.
Yeah.
What did you do wrong, Dr. Ofri?
Yes.
It's of course, it's so frustrating to get the blame for this type of thing.
Let's talk maybe a little bit more about trust and fear and misinformation. I mean, you come across as just so dedicated and trustworthy. This maybe is not a problem for you and your patients, but in an age where patients are bringing in TikToks or Twitter threads as their kind of evidence that someone is telling them I should be on this medicine or I shouldn't be on that one, what do you think it really takes to build trust with a patient?
And I think we can go back to the basics. So one of the things I try to talk to my students about, as it's just a small technique, but it's indicative of something larger, is for the first 2 minutes of the visit, don't use the computer. Just do full frontal listening. Ask the patient what's going on. Don't say a word for a minute or 2 minutes. You have no idea how long 2 minutes of focused listening. I mean, when's the last time you spoke to someone who didn't cut you off, look at their phone, or do something else within 10 seconds? And it's symbolic. It's also critical. And if we can just hold back for a minute, I think we'd make less error because the patient gets out all the things they wanted to say. It's an investment of listening. And to tell the patient that I'm here to hear what you have to say. And so what I'll often say to a patient, say, hey, listen, often in medicine, we don't have names for a lot of the things that patients are experiencing. We may not have a disease name or a diagnostic category. Um, that just shows the limitations of medicine. There's things we don't know. It doesn't mean we can't investigate this or even treat this. And so it's like you and I are now going to be this little research team on a clinical trial with an N of one. And so we're going to collect some data. So, what I'll need from you, and I'll, keep a symptom diary, bring it in. Let's try this or that. You let me know how it goes. It may not be perfect, but can we dial back the needle a few degrees like that? Could that be success if the pain is a little less often, or we find something? And even if I can't solve many of these pains, which trust me, I can't, I think even making that kind of effort, that you're taking them seriously, you're trying to help them, even if you can't solve it,
Yeah.
goes a long way.
Do you have any special tricks or one-liners you use to try to win people over when maybe you feel like they're shutting down and not wanting to hear your side of things?
Yeah, I just say, "Woo, sounds like a lot is going on," You tell me what's going on or tell me what you're feeling, just to sort of acknowledge in the moment, boy, this is a lot that's happening right now. Let's take a minute break. And also, I'm so glad you came today. I know how hard it is to get here, how much effort it takes. I'm so appreciative that you made the time to come and to listen to me. I may be blathering off for too long, but it means a lot that you made that effort, and I will try to do the same. Some acknowledgement of where people are, and then sometimes I'll ask, how could I best help you? We're in this intractable situation. I don't have an easy answer. What would be most helpful for you in this moment? And sometimes you'll be surprised what that answer is. It may not be solve this medical problem. It may be, help me figure out how to get this medication, or how do I get home today, or some other simple thing. We don't always know. We assume what's the patient's biggest priority, but we often don't know. Um, I spend a lot of time trying to ask people about their background in their life, especially on the first visit, where they're from, if they're from another country, how they got here, who they live with, what they do, just to get a sense. And very often, patients from other countries will have done some other career in that country, but now work as a cab driver here. But I'm always intrigued to know they were an economist back in Jordan.
Right.
Um,
Yeah.
and ask them, oh, what did you study and what were you doing? Just some genuine interest. I try to remember these things and write them down. I have one patient with a grown daughter in her home country with cancer, and she can't go back,
Mm.
the mother, because of immigration issues. So,
Yeah.
of course, it eats at her. And I've written it down in my notes section so I can ask. I start each visit asking how that daughter is, because if I don't, that's the most important thing. She couldn't give two shits about her, hypertension, even though I care about that. But
Yeah.
I want to address that first, see how that is, and then try to get to the other things.
It is so important. I think patients can really feel like a number. They can feel like they're being just kind of like worked through an algorithm. And the more that you can do, like, literally what is the practice of medicine, which is like take a unique individual with unique circumstances and medical problems and medications and allergies and symptoms and signs, and come up with a plan to try to relieve some suffering, maybe get to a diagnosis if you can, reduce risk and kind of harm reduction. That's ultimately what we're trying to do in medicine.
Yeah, I always feel like our goal is just to shift the needle a little bit, right? We can't solve most of our patients' problems, short of like, appendicitis, great, take that out, pneumonia,
Yeah.
antibiotic. But 95% of the problems that you see in the ED or I see in the clinic are insoluble. They're chronic, they're multifactorial. There's no one-shot cure. And so can we ease the suffering a little bit? And sometimes easing the suffering might be getting better shoes, or some some small thing,
Yeah.
getting a food supplement, supplemental benefits can help. I don't know, there are all kinds of things, and you don't know until you ask to find out what's really, what are the biggest struggles for the patient right now.
Yeah, that's I think one of the reason that there's a rise in influencers and wellness people is they are promising cures. We are offering management solutions to try to, right the ship. But the influencers are offering, hey, this will cure your XYZ.
I always say, like, if there was that one odd vegetable that cured cancer, we'd be on it. We wouldn't be holding it back. You know,
Yeah.
I'm all for it. I mean, I do say, if you do want, if I had to pick one magic pill, it would be exercise.
Absolutely.
Physical activity will benefit just about every illness out there, including psychiatric, medical, surgical. If we can make a shift of, 10 more minutes of walking a day, that'll probably redound to some improvement in the things they are suffering with.
Ezra Klein's last week, he had a thing about Maha, and the title of it for the New York Times was something like, Maha is asking the right question but has the wrong solution. And that really resonated with me because I think every physician in the country would say, yeah, we would love our patients to eat more vegetables and healthier food and move and exercise more and improve their sleep, because we all agree all of those things are critical to health and reducing chronic stress and chronic disease as well.
Yeah, I mean, it kind of pisses me off that he's like, acts as though we've never thought of this before. Like, oh, hey,
Yeah,
news,
Oh,
news
it's a
alert,
novel idea.
right?
Yeah.
Chronic illnesses. Well, yeah, we've been struggling with that. But yes, absolutely. And thank you for bringing up sleep. That's the other one that is getting one good night of sleep, man. That goes a long way to helping chronic pain, hypertension, many, many, many things.
Dr. Ofri, in our last few minutes, I'm just curious if you are using any of the new AI technologies, and if you have any opinions on them.
I do have colleagues who are using ChatGPT for writing appeal letters, and prior
Sure.
auth. Go for it. I'm a little leery about, diagnostic work on
Absolutely.
that.
As you should be. Yeah.
Yeah. You know, I think there's some helpful things. Again, I'd rather have an extra nurse or extra medical assistant. I think that would have a bigger impact on my life than the AI tools. So a jury's still out. I mean, I'm definitely thinking about it. And I think obviously in primary care, it's estimated to take 27 hours a day if you did all the primary care things. Like, yeah, this could be done, So I just, I worry that it's just going to be used then to give doctors more patients. So,
Absolutely. Yeah.
like
That's
not
the
like,
concern.
oh, right. It's just going to, okay, hey, now the doctors can see the patient 8 minutes instead of 10 minutes because
Yeah.
they have AI tools. So, and I'd love to see some clinical trials. Like, we threw in Epic and EMRs without really doing any testing of harms. And I imagine AI could do harms. And who's responsible when something goes
Absolutely.
wrong? Do I want to get sued because ChatGPT made a mistake? No.
Yeah. Danielle Ofri, it has been an absolute pleasure to get to talk to you. Your articles have absolutely changed the way I view and see the world and my career and my job and my health system. So I just want to say thank you so much for being here. It's really been a pleasure to talk with you today.
You're welcome. It was lots of fun. Thanks.
Thanks for joining me today. For interviews with physicians creating meaningful change, check out offcall.com/podcast. You can find How I Doctor on Apple, Spotify, or wherever you listen to podcasts. We'll have new episodes weekly. This has been and continues to be Dr. Graham Walker. Stay well, stay inspired, and practice with purpose.